Professor of Radiology and Director of GI Imaging. His topic today is GI fluoroscopy case review, and he will discuss GI fluoroscopy from stem to stern. So please join me in welcoming Dr. Fleming this morning, or this afternoon. You might want to just advance. Just tell them that we're working on that.
A small technical issue being worked through here, I believe.
Ready?
Terrific. Good morning or afternoon, however your day finds you. I'll enjoy talking to you about one of my favorite topics, and that's GI imaging, but particularly fluoroscopy. The role of fluoroscopy has changed dramatically in the last few years, which is obvious to all of us. Endoscopy has pretty much taken over what occurs anatomically in the esophagus and the stomach and what occurs anatomically in the colon. But we still have a great deal to bring to the clinical decision-making process. A lot of that has to do with post-interventions, and so the cases I'm going to walk through today are not necessarily the typical things that you see in a GI assessment going from stem to stern. Again, those of you who are sailors know that's from the front of the sailboat to the back, which is sort of the approach we're going to take to the human body. I'm going to start off talking about swallowing. I'm just going to be fairly brief on the control of swallowing and so forth, because I'm giving a more in-depth discussion of swallowing disorders here in a couple of weeks. But that being said, I don't think we can talk about the alimentary tract without giving it its due, if you will. Swallowing is both ancient and complicated. Ancient meaning it's simple. It's a fundamental reflex that is governed by our ancient brain, but very complicated in that our neocortex has made it more sophisticated over the years. That said, when you assess a patient's swallow, you have to be attuned to the fact that there are several layers of pathology that can occur. It might be with the muscle itself. It could be a peripheral neuropathy. It could be the cranial nerve sending the signal down from the brainstem. It could be in the brainstem at the swallowing center in the medulla. We'll talk about that another time. But then there's the cortex that gives information afferently from above. What you see before you put it in your mouth. What you remember about the experience the last time you did. That said, when you look at an image of the skull base such as this one, and you look at the left CP angle, you'll see a glomus jugulare, which is embarrassing the glossopharyngeal nerve, which really embarrasses swallowing. And as you can see in this patient, here the contrast is taken into the mouth, and in general there's the oral phase, pharyngeal phase, and esophageal phase of swallow. The oral phase is pretty much volitional. There's some muscles of mastication that are governed in a rhythmic fashion. But once the bolus makes it into the pharynx and hits the base of the tongue, the pharyngeal trigger occurs. A cascade of pharyngeal muscles all contract in a time span of about 0.9 seconds. Three things have to occur to protect you at that point. One is the tongue closes off the mouth, pressing against the soft palate. The second is the soft palate presses against the back of the pharynx at posivance ridge, closing the nasopharynx off. And more importantly, the epiglottis flips down, covering the airway, covering the vestibule. Synchronous with that is the closing of the cords themselves. So the airway now protected, the bolus can go through the pharynx, the cricopharyngeus will open, and the esophageal phase of swallowing begin. So clearly, looking at this patient who has impingement on glossopharyngeal nerve, there's a terrific failure in swallow because you have contrast in the mouth, contrast all the way down to the piriform sinuses above cricopharyngeus, and you can see a small tract of contrast going along the airway. This patient's aspirated, and the vestibule was unprotected. So assessing the swallow with video fluoroscopy is still very much the standard in the United States. The incidence of swallow evaluation as baby boomers get older has gone up. So a skill that we very much need and is active in our clinical milieu. Other things can cause dysphagia and difficulty swallowing, which is fairly obvious in this case. If you look at the spine, you see that there's a diffuse fusion of bone anteriorly and a gigantic spur. Clearly, when this patient's epiglottis tries to tilt and hit the inferior aspect of the vestibule, it bumps into that spur. So the patient was aspirating continually. So that led to surgical intervention, which looks like this. Now if you look at the prevertebral space, you've got about 3 centimeters of edema. Now the patient has dysphagia for another reason, obviously, postoperative. Fortunately, this will improve, this will go away, and the patient's swallow will return to normal. But the important thing is being aware of that, because a failed swallow can be treated a number of different ways, which I'll go into more in a couple of weeks. But making sure the patient doesn't aspirate is critical in preserving their health, no pneumonias, and making sure still on the other side of it they get adequate nutrition. A little sidebar on this one, also this prevertebral thickening is really common in anyone who gets an anterior fusion in the cervical spine, and some would say up to half patients who have a cervical disc procedure anteriorly will also have dysphagia, at least of some duration. Now, this patient presented with dysphagia, about a 62-year-old, negative history prior to that, and what you can faintly see on this scout image, you can see better after introducing a little bit of contrast. You see a well-circumscribed lesion extending from the base of the tongue, and this is a primary squamous carcinoma. Her only presentation was fairly subtle dysphagia, particularly to solid foods, but obviously surgical candidate, and that was the next step. This one, a tumor obviously in a different place, but be even more a direct cause of aspiration, because here if you look at the epiglottis, there's this mass that's sort of multifaceted hanging off the epiglottis, which couldn't tilt at all. So again, that led to surgery, which leads to our next role in evaluation with contrast, and that's the postoperative pharynx. Most typically what we're looking for is, number one, is there a leak? Number two, is the neopharynx, is it patent and fairly? Do we have any strictures? And that being said, most typically you start off with water-soluble contrast, and in doing so you can get a pretty good look at both of those two questions. That being normal, then you can go to some thinner thick barium to further delineate the pharyngeal wall. This is a typical appearance. You can see the outline of the neopharynx, no leak. Now this is also a more mature postoperative appearance after patients had a laryngectomy. And something I want to draw your attention to, if you look anterior to about C5, 6, you see a bulge posteriorly. And this is a normal finding in this setting. When the cricopharyngeus is cut anteriorly, the fibers tend to retract and give you a smooth bulge posterior to the neopharynx. It's important to distinguish that from recurrent tumor. Can the two be confused? Perhaps. But recurrent tumor usually is irregular, doesn't have the smooth contour, and location helps you out a lot. So this is a fairly typical appearance. Here a small stricture has occurred in the neopharynx. The patient was having some difficulty with solids. The doc can then go back in and dilate that, and usually the patients will do well. Another example, the same thing, except a little bit worse. Here the neopharynx is bulging anteriorly, and you can see the stricture has a more AP orientation. This is a more regrettable circumstance, but again, where fluoroscopy comes into play. In the immediate perioperative period, the patient needed an NG tube. An NG insertion was attempted, which went through the posterior pharyngeal wall and into the left chest. Ended up putting a chest tube in, draining out. We saw the patient a week later, and here's what's left of that original tract. It's healing up nicely, not tracking into the thorax anymore. Again, this was done with water-soluble contrast. But we can see that below the neopharynx there's a pretty long stricture, and that'll have to be addressed. This patient is being fed entirely by PEG at this point. And here they come back again 2 weeks hence. You can see now the tract is very small, maybe a centimeter and a half, but the stricture is worse. So the clinical plan here, a little more time, allow that tract to completely close off, and then go in and dilate the stricture, and then hopefully get the patient back to PO feeding and off the PEG feeding. Anytime you evaluate someone postoperatively in the neck, most would start off with water-soluble contrast, then go to thin barium or thick barium. But you need to understand what's going on with the patient clinically before you make that decision. This is a patient sent to us after a total thyroidectomy, a vigorous bilateral node dissection to assure that there wasn't any leak. Now, the water-soluble contrast, as you know, is iodine-based. So how might this confound what's going on with the patient? Well, where are they in their therapy timeline? If the patient hasn't already been given their I-131 for therapy, which they would do in this case, giving them iodinated contrast could attenuate the ability of any remaining thyrocytes to take up the therapeutic iodine. So what we did was with some trepidation, talking with the patient, we felt pretty sure there wasn't any clinically. And again, thin barium in the neck isn't the worst thing, so we carried on with some very thin barium, saw there was not any leak, which was the right decision because the patient, as we finally figured out, had not been given their I-131 therapy. So the therapy wasn't impeded, and the patient didn't have a leak and ended up doing fine. That's important because here's what the primary tumor looked like in the thyroid on the right, and even more critical is multiple pulmonary nodules. So loading this patient with oral iodine would have been a significant disservice and slowed down his therapy by multiple weeks. This is another patient presented with dysphagia, and this is the CT to go along with it. Now, clearly, this patient has had multiple episodes of aspiration. You can see the pleural loculations bilaterally. The question is, what was the source of the dysphagia and why the recurrent aspirations? See a faint lucency just in front of the cervical spine inferiorly, behind the pharynx. And if we press on, give a little contrast on the CT, now we see that. And a couple of things come to mind. Could this be a diverticulum? Could it be a duplication? And when you look at the sagittal view, it becomes perfectly apparent. This is characteristic appearance of a Zinker's. As you know, Zinker's diverticulum is midline diverticulum. It goes through Achilles dehiscence just above cricopharyngeus, and it can be big. And it can be a problem because it can store food. A typical story is a patient will say, you know, what I had for lunch yesterday came in my mouth this morning, or pills I took yesterday came in my mouth this morning. And recurrent aspiration is not uncommon. So it's a surgical question. This is a typical appearance AP of a Zinker's. You can see it's totally in the midline. And there is a contrast study of a Zinker's. Very helpful for the surgeon to get a good look at how big the neck is and exactly where the neck of the diverticulum is. Here you can see the Zinker's compressing the actual food channel anteriorly, so the dysphagia was really worse when the Zinker's was packed. This is an AP chest radiograph. It was a preoperative film for another reason. But if you look to the right of the trachea, where the esophagus is overlying, you'll see another lucency. And this is a Killian-Jamieson diverticulum, which occurs below the cricopharyngeus and tends to be lateral, as opposed to Zinker's, which is in the midline. But as far as dysphagia and aspiration, the same issues appertain. Other diverticula can occur in the esophagus. This case is interesting in that there are a couple in different places. Here you see a diverticulum above the diaphragm to the right. Interestingly enough, the patient also has a diverticulum off the fundus of the stomach, which is, if a diverticulum comes from anywhere in the stomach, it's most likely going to be in the cardia or in the fundus. And above it, you can see the epiphrenic diverticulum. Interestingly enough, if we go back to the initial image, see that there's an extrinsic compression on the esophagus just right about the AP window. It turns out that in this patient, that ends up being a neurofibroma, and there's a 3D rendering of the diverticulum, and there's the neurofibroma pushing on the posterior contrast-filled esophagus. Other impressions on the esophagus can cause dysphagia. This is actually a physician with a very eloquent description of what her problem was. Every time she would swallow, she would get it halfway and then have to kind of give it a push. But you can see there's an oblique line going across the esophagus, and this is dysphagia lusorum. This is the aberrant right subclavian artery going across the esophagus, causing the symptomatology that she has. Now, most of the time, that anomaly causes no trouble at all. It's an oh, by the way. But if the patient has dysphagia, then you can have reimplantation of the artery and the dysphagia will be improved. Now, historically, we think about doing an esophagram for someone who has esophagitis. And in the large patient population we have who have HIV, certainly doing an esophagus evaluation with contrast occurs from time to time. Most of them, candidly, are handled clinically. But we do see them sometimes, particularly if the esophagitis is bad and if there's any risk for fistulization. If you look at the contrast column in this patient, it's shaggy all the way down. And this is a combination of a patient who has both Candida and herpes. Candida usually the shaggy appearance, herpetic esophagitis usually small ulcerations, CMV and HIV together usually give these big, deep aircraft carrier type ulcerations. But this is appearance fairly typical of someone who has a couple of different kinds of esophagitides superimposed. Clearly there would be dysmotility in that esophagus just because of the inflammation. But Other etiologies of dysmotility can also give you dysphagia, difficulty particularly with solids. And this is a not uncommon scene. As you can see, the esophagus here has a real rippled appearance distally. You would almost think that this is spasm, and that wouldn't be a bad guess at all. But if you watch even closer, you end up with what look like almost pseudo-diverticulae. And what this is the form frust, or what happens before this appearance. Now the esophagus is massively dilated. It contains food material from several days before. And now you work your way down. You could see that on a chest radiograph. You see a standing air fluid column. And then classically at the GE junction, you have the bird's beak. So what we're looking at here is obviously achalasia. But the point I want to make is this is into the road. Here, the esophageal wall is pretty much given up on trying to contract against a closed lower esophageal sphincter, which is what's going on here. So this is vigorous achalasia. You have strong contractions against a closed LES, and ultimately an atonic dilated esophagus with the characteristic appearance of achalasia. Now, again, all achalasias aren't what we think of as idiopathic, autoimmune, and so forth. The other subset that's important to keep in mind is pseudoachalasia. Pseudoachalasia is a different entity entirely, usually seen in older patients, and it's usually seen with infiltrative processes involved in the GE junction. Most typically it's going to be either a primary tumor, a GE junction primary gastric tumor growing proximally, or metastatic disease. This is a patient who is 12 years out with the diagnosis of breast cancer who came in with dysphagia. And this is what the GE junction looked like, with a fairly vigorous pattern above it, and that's metastatic breast disease presenting as atypical or as pseudoachalasia. Here again, this is a GE junction primary, and you have that corkscrew appearance of the esophagus, just like you did with typical achalasia, but this is pseudoachalasia, infiltrating process at the GE junction. This is a similar appearance, only this is a patient with lung cancer as the primary. Again, pseudoachalasia, dilated esophagus, but with tumor as the culprit. If it's a GE junction primary, you've probably encountered different staging systems. Some break it down, is it above the LES, at the LES, bridging it, or below. Esophageal tumors that are below the LES in the gastric cardia are still considered oncologically and by surgical oncologists to be esophageal primaries, and so treated as such surgically and otherwise. This is such a tumor. This is a patient who presented with pseudoachalasia with an infiltrating GE junction tumor. If you use a Siewert classification, this would be a Siewert 2. You can see circumferential thickening of the esophagus. And as you can see here, clearly not an operative candidate on the coronal CT. Extensive periaortic adenopathy extending down into the level of the bifurcation. So the patient was stented and treated with chemoradiation, interfluoroscopy again. You can see the stent has ridden above the tumor itself. Contrast study shows that it gets to the GE junction but barely gets into the stomach. So the stent was manipulated, and now you can see it bridging the tumor. In contrast, and food are able to into the stomach, so the patient can continue to feed PO. There you can see a stent bridging a tumor that has been treated with radiation and chemotherapy, and one of the untoward effects that can occur with that is leak. Now, anytime you evaluate a esophageal stent, post-traumatic esophagus, post-surgical esophagus, you can start off with water-soluble contrast. And if you're not sure, because there are a lot of shadows and it can be difficult to see, you can always go to CT, in which case here you can see a little bit of tumor climbing in through the stent, but no leak out into the mediastinum. Here's a patient who presents also for evaluation of the esophagus, but this is after a TEH. In patients who have esophageal carcinoma, the two primary surgical approaches are going to be thoracotomy with an Ivory-Lewis, or it's going to be a transhiatal esophagectomy. That's the case in this individual. If you look at the lateral scalp, there's a lot of gas in the soft tissues of the neck. AP, you can see the gas tracking in the soft tissues. And the way this surgery is done, the GE junction is resected, then the physician makes an incision, pushes the rest of the stomach up through the mediastinum and exteriorizes it usually in the left supraclavicular space. The remnant of the esophagus is then sewn to the gastric component, and then drop back down into the chest and anastomose. So when we're looking for a leak, that's usually where the money is. So we'll give the patient some water-soluble contrast. And one of the reasons I'm showing you this is a typical appearance. We'd like to think that the stomach pulled up gives us a nice end-to-end with what's left of the esophagus, but it doesn't. You'll see a flange of contrast going off to the patient's left. There's often a nub of stomach that heads up in that direction, so then the onus on us to make sure that that's not a leak tracking towards the surgical site, but rather really is within the pull-up, which is the case here within the pull-up. There again, the different patient, the same thing. You see that little beak going toward the supraclavicular space. And here's one that is a leak. We couldn't get that to empty. That was in the paraesophageal space, and so that's a good example of a leak. If you wonder about it, you can always, again, go to CT. And here in this case, the contrast is within the pull-up, but you can see with that beak configuration, that can be sometimes difficult to tell fluoroscopically. Now, not only the stomach can be pulled up to bridge the esophagus. In this case, we've got a jejunal pull-up, clearly jejunal folds. Again, jejunal pull-up. But if the jejunum can't be used, you can always use colon. This patient had difficulty with eructations after eating, so manipulation was done where the patient would turn to the right after swallowing, closing off the pharynx to the right and allowing the food to empty in the pulled up colon, and was able to eat and swallow and not have the eructations anymore. It worked out quite well. But the intervention was done during fluoroscopy to see if it worked. Pull-ups are subject to inflammation just like a native esophagus is. And here is esophagitis with herpes in a patient who has had a pull-up. You can see the ulcerations in the mucosa. Other complications involving the esophagus. This patient had a pneumonectomy on the left. The left chest kept filling with fluid. So evaluation with CT showed, which you can see, a fistula from the esophagus into the left hemithorax, air fluid level. When you look at it with contrast, you can see there's no leak until we really flood the system. Excuse me. And there you see the tract going out into the left chest. The patient was stented, that closed off, and ended up doing quite well. Making our way further south. Now we're down at the diaphragm. And this was a preoperative chest where a patient was going to get a CABG. And there's information on here that's critical for anyone who's going to go into the mediastinum, and that's the fact that this patient has not one, two, but three diaphragmatic hernias. There's a large Morgagni hernia to the right, peristernal, which is uncommon. And then we have a paraesophageal hernia and a hiatal hernia, all three together. So something a surgeon would really want to know before going into the chest. We can evaluate those, obviously, using contrast. Here's a patient who has a paraesophageal hernia with organoaxial rotation of the stomach up into the hernia sac. As you know, the malrotation of the stomach can be either organoaxial or mesenteroaxial. Organoaxial is the type of rotation that occurs along the short axis and can give you more likely strangulation of the stomach. The types of hernia that occur are broken down into type 1, 2, 3, and 4. Type 1 is a typical hiatal hernia, sliding or fixed. Type 2 is a paraesophageal hernia. Type 3 is hiatal and paraesophageal together. And a type 4 is where you have a type 3, but some of the mesentery or viscera is sucked up with it. That can be tail of the pancreas, some mesenteric fat, but that'd be a type 4. This is a patient with a gigantic type 4. You can see the esophageal and the paraesophageal component. Difficult to empty the esophagus. You can imagine they're having dysphagia. Organoaxial malrotation of the stomach. On CT it looks like this. You can't see it on this image, but the tail of the pancreas also came up into the chest. And lesions within the stomach. If you look at the superior aspect of the fundus, you'll see a halo extending down into the lumen. Fairly characteristic appearance of a GIST tumor. GIST tumors, as you know, sort of evolved from the lexicon of leiomyomas as the most common benign tumor in the GI tract. They're KIT positive. Most would consider them malignant depending on how many mitoses are present. But usually well circumscribed. They extend into the lumen like this. But still you have to prove this is not an adenocarcinoma first. You can't assume it's a GIST. But it is a typical appearance of a GIST tumor. You can barely see the GIST here on an oblique view. This is a patient who presented with gastric outlet obstruction, and the thing that strikes you the most, there are no rugae. and the patient could have atrophic gastritis either because ongoing infection with H. pylori, it could be autoimmune. Turns out this is H. pylori related, and the GE, and there is an antral adenocarcinoma. As you know, the relationship of adenocarcinoma and H. pylori is very much parallel. Where that tends to depart is in the proximal gastric tumors. But that said, this is a characteristic appearance of gastric outlet obstruction due to a distal tumor in a patient with atrophic gastritis. For a serous carcinoma of the stomach, this is the typical appearance. It's a rigid wall, comes to a beak. The other thing you might think of this is the ram's horn appearance of patients with Crohn's disease. As we make our way into the duodenum, this is an unlikely presentation just a couple of weeks ago of a girl who came in the ED with abdominal pain. And as you can see, contrast normal stomach, duodenal loop, but then a pool just after the distal genu of the C loop. And this is a perforated duodenal diverticulum, diverticulitis with perforation. You'd also think, could the patient have Zollinger-Ellison syndrome, an ulcer in an atypical location that would be bleeding? What argues against that? We don't have thickened gastric folds, and also you don't see gastric ulcers. So that helps us out there. And this is the same appearance, same individual on a CT scan. Evaluating postoperative patients in the duodenum. Here's a patient post-Whipple, and you can see a stricture in the gastrojejunostomy. So your differential here is going to be inflammatory stricture versus recurrent tumor. Fortunately, this was inflammation, and dilatation improved gastric emptying. The patient did fine. It can be more difficult than that. This is a patient who had a stent because of pancreatic tumor inoperatively invading the C loop of the duodenum. There are the stents in place, but the patient again was having gastric outlet problems. And we see contrast coming in, going through the stent in part. But if you look at this proximal aspect of the stent, what you can see is the lumen of the stent proximally isn't the same as the lumen distally. There's a better picture of it. And what's happened is tumor has grown into the stent, so the true lumen of the stent proximally is significantly compromised by tumor, which is recurrent. The patient ended up going to a gastrojejunostomy to try to temporize a bit, but good example of stent involvement with tumor. This is the same patient showing the dilated stomach on CT and the tumor infiltrating around the duodenum. Press on past that case a little bit. Moving on into the small bowel. This is an image from a small bowel series. Now, there's something that should strike you about this right off the bat, and that's we have reversal of folds. If you look at the small bowel on the left, you see that there are essentially no folds. If you look at those on the right, there are folds. This looks like the jejunum on the left has been changed to ileum. If you looked at this de novo, and this was a small bowel series in someone who didn't have malrotated bowel, this is the typical appearance of celiac disease or sprue. And you have jejunization of the ileum. A phenomenon called adaptation. Anytime you have insult that diminishes the ability of the small bowel to absorb what it needs to, the rest of the small bowel can undergo hypertrophic change in the villi to make up the difference. That's what occurs in celiac disease. And continuing on in this patient, you can see that, again, small bowel appearance of malrotation versus sprue, but it turns out here, if we go backwards now to the first image, this is actually malrotation. The ligament of Treitz is in the midline, and the jejunum starts on the right, and that truly is ileum on the left. So the two things to think of are either you have inflammatory bowel disease such as sprue, or you have malrotation. And watching where the bowel shows up with folds first would tell you the answer. Interestingly enough, this person with malrotation did in fact have a terminal ileum that looked like this. A stricture, long stricture, fairly characteristic of Crohn's disease. A host of other entities can give you a stricture like this. Long use of NSAIDs, tumor, post-bleed, but Crohn's disease is the fast horse, and that's in fact what this is. Back to sprue for just a moment. Sprue can have other complications downstream, particularly refractory sprue. Those particularly have to do with T-cell lymphoma, increased risk of adenocarcinoma, formation of strictures, and this unfortunately is an individual who is way down the road in their clinical trials, if you will, with sprue, who's developed an adenocarcinoma in the fourth portion of duodenum. But then if you look at the stomach, there's a fixed pattern there, and this is enteropathy-related T-cell lymphoma. Usually the T-cell lymphoma is associated with enteropathies occur where the enteropathy exists before, so typically jejunum, as opposed to usually the lymphomas that involve the GI tract tend to be toward the TI, or in the case of malt lymphomas, the stomach. But this is regrettably a case of a patient who had two of the problems downstream of sprue, and that's adenocarcinoma and also T-cell lymphoma. As far as adaptation goes, any insult other than inflammation can also give you adaptation. This is a patient who had undergone a gastric bypass for weight loss. At this point in the small bowel, you can see the jejunum is normal on the left. You can't see the gastric remnant going to the gastrojejunostomy. The loop you see refluxing back to the midline is her native loop, a little contrast there. But a problem was intermittent pain, and everything so far looks good. But as I got down near TI, you'll see a band. Now, her cecum is immediately to your left, and you can see the TI is jejunized. Lots of folds, and then there's a transition point, then the ileum looks normal. So this is adaptation distal to an adhesion. Adaptation can occur distal to trauma, distal to surgical intervention, but this is adaptation to small bowel or hypertrophy and hyperplasia of villi distal to an adhesion. Here's a patient who has a small bowel series. We'll look at the small bowel on the left and see that there are some saculations, a couple of small jejunal diverticuli. She is downstream of Crohn's disease and has really done quite well. She has a neo-TI, which is what we want to evaluate the most, but she does have small bowel diverticuli, which also can give her malabsorption. And here you can see her neo-TI is sort of a mat of really dysmorphic residual ileum into her colon, and her colon filled by several channels through the dysmorphic ileum. But it emptied well, didn't seem to obstruct, and the small bowel wasn't dilated. So difficult to tell. Is her problem because of her diverticulosis and bacterial overgrowth, or is her problem because of recurrent Crohn's? She was going to go to surgery and have this resected. It's not uncommon, too, in patients who have inflammatory bowel disease to come to us through the portal of eating disorder clinics. This is a patient who had been through clinics for the last 12 years with various eating disorder diagnoses and finally came to a small bowel series. And this was de novo. As you can see, the jejunum is grossly abnormal, and there's this giant sacculation in the pelvis that looks like this. There's nothing normal so far going all the way to the ileum. That is her distal ileum, that gigantic loop. That's not colon. And if we look closer, we can see a very, very tight stricture. This is occult presentation of Crohn's disease. She was put on medication, came back to see us here just a few weeks ago, and was remarkably better. And in fact, her jejunum looked great, ileum looked good. The only thing she had is a small area you can see in the center of the screen, two small strictures, but her symptoms were almost nil. Interestingly enough, she was continuing to go to the eating disorder clinic. It becomes sort of a chicken-egg question perhaps in time. Again, jejunal diverticulosis. This is a patient who had mixed connective tissue disorder, and so they can develop a number of problems relative to the small bowel. And so her diverticuli were true diverticuli, not pseudo-diverticuli, which you can see in patients who have different kind of autoimmune disease, such as lupus or scleroderma. But that said, these are true diverticuli, and this is at 3.5 hours. Those diverticuli are still completely full of contrast, reflecting the overgrowth problem she'd be dealing with. If you look at this patient, you see a good look at the stomach. The jejunum looks pretty good. And the finding, though, is right in the middle. See, there's sort of a saccular collection of contrast. This is a patient who has a sacculation that's not a diverticulum. This is lymphoma. Lymphoma or Crohn's can give an appearance like this, but a sacculation in the small bowel, we have really infiltration, loss of the normal smooth muscle. Lymphoma is one of the things you think of predominantly. This is an interesting case just a couple of weeks ago, again, to our outpatient center. This is a scout view for an upper GI and a small bowel. And if you look at the transverse colon, look at the pattern. Those are not normal haustra. This is characteristic what we would call thumbprinting. Usually you see that associated with either C. diff or ischemic bowel, but this guy had a history of pancolitis secondary to ulcerative colitis, and they were thinking about a total colectomy and wanted to make sure his small bowel was normal. We did a small bowel series. It's absolutely normal. And if you look at the TI, he doesn't have backwash ileitis, like you often see in patients with ulcerative colitis. But if you look at his cecum, it doesn't look normal at all. You would call abnormalities within the colon on a small bowel series with great trepidation, because obviously the colon hadn't been prepared at all. This is another patient with UC who presented really in extremis. The colon doesn't look like that dilated on the KUB. On the CT, it's horrifically so. So we did a contrast evaluation on her, a retrograde, multiple dilated loops, and were able to evaluate and identify where the stricture was. She had so many comorbidities, not a good surgical candidate. She ended up going to surgery and doing okay. As you can see, typical of UC, she's lost all the normal morphology of her colon on the left, no normal folds, and there's her stricture. Typical appearance of colorectal carcinoma, we always like to see an apple core, but it can be otherwise. This is a primary adenocarcinoma of the colon arising within a polyp, filling defect. This is the characteristic thing we see. This is almost historical because now this sort of lesion is usually seen by colonoscopy and biopsy. But this one did come through occult bleeding and evaluation with a contrast enema. More typically, if we're going to do an enema on someone, it's going to be post-operative to evaluate a pouch prior to dropping an ileal bypass. So here's a patient we've given gastrografin retrograde. We're filling the left colon up to near where an ostomy is. But what we were looking for, we found, and that's a leak at the anastomosis at the pouch. And if you look in the presacral space, you can see contrast is tracked all the way back in, anterior to the sacrum. And these can be very clinically occult. But the patient is not sealed up enough where they can reverse their ileostomy and having, again, the empty from below. Scout view of a patient who's having an evaluation of small bowel. And the interesting thing you'll note, everything looks orthotopic to here. I went to spot the terminal ileum, and I couldn't find it. I rolled the patient right side up, and the terminal ileum was residing under the transverse colon, which is not where it should be. And so I pulled up the CT of the patient, and it's orthotopic. But the CT is done with the patient laying on their back. This is a case of wandering right colon. It's sort of maybe a grandfather of a malrotation of the cecum, cecal volvulus, bascule. However, here the whole right colon goes. As you know, when the rotation of the bowel occurs in utero, the right colon is the last thing to get tacked down in that minus 270-degree rotation of bowel. In this patient's symptoms, because every time she rolled right side up, her whole colon would flex to the midline. Well described. Colon isn't all bad and causing trouble. Here's a patient whose colon was harvested to the good. She had a cystectomy because of a urothelial tumor. I got her help in cannulating her ostomy. Contrast was introduced, and her right colon had been harvested, and here the colon is functioning as a neobladder. You can see the reflux into the ureter there. And this is a study that's not done too often anymore, just using retrograde contrast. In fact, this is not retrograde as you'd think of with a barium enema. This is defecography. More typically it's done with MRI, but it can be done using retrograde contrast. When you do it, you want to evaluate all three compartments. You'll put contrast in the rectum, you might put it in the vagina, and you might have contrast in the bladder. That's to allow assessment of, number one, in the posterior compartment, does the patient have a rectocele? Does the patient have a prolapse? In the middle compartment, is a rectocele causing any impediment in the vagina? And anteriorly, is there a cystocele? You might also give contrast in the small bowel to see if an interocele interposes itself down into the pelvic floor. Here you can see there's only one compartment filled. And that's because this patient presents with a somewhat unusual diagnosis, and that's solitary rectal ulcer syndrome, which is a bit of a misnomer. They typically occur in patients who have sometimes a psychiatric overlay. This individual was bipolar. They're usually not solitary. Usually can be multifocal, seen at colonoscopy, and often there are no ulcerations. It can be small polypoid masses. That said, at colonoscopy, this male had a history of bipolar disease with multiple small ulcers and severe difficulty with constipation. So sent for defecography. Here it was done fluoroscopically. About 200 cc's of contrast was introduced into the rectum. And then on the fluoro table, defecation was attempted. Now what you can see is there are bands going across the rectum, and here you see partial intussusception, which is something that's seen typically in patients with this solitary rectal ulcer syndrome. Intussusception, complete prolapse can occur, and here this is intussusception that is incomplete. The other thing that you look for in defecography most typically is there descent, an abnormal descent of the pelvic floor? Is the integrity of the pelvic floor maintained? In doing so, you'll then look at landmarks like the distal sacral segment to the inferior pubis and generate the pubococcygeal line and use that as a reference point to normal or abnormal pelvic floor descent during defecation. That being said, I think I will end my comments there, and could you please go to your polling section and give you a minute or two to do that, and we'll go over the questions. Okay. If you've made where you need to go, probably have to go to my different visual distance here. So question number 1. During a normal swallow, which of the following occurs? Soft palate compression against positons ridge, closure of the chords, inversion of the epiglottis. All of the above. I'll give you a second to formulate your answer. Obviously, the answer is all of the above. The soft palate compression against positons ridge is essential because you want to close off the nasopharynx. Otherwise, you have nasopharyngeal regurg. Closure of the chords is really critical because if you think it's sort of the last stop, if you will. Even if there is any contrast that makes its way past the epiglottis, if the chords are closed, the airway is still protected. And you'll see a lot of patients will cough material up if it's in the vestibule and the chords are still closing off the airway. So the answer to that one is all of the above. The next one. The smooth posterior bulge, often seen posterior to the pharynx after laryngectomy, most likely represents duplication cyst, retracted cricopharyngeus, recurrent tumor, or none of the above. Well, as you know, I'll give you a second to think about it. I showed you the case of the neopharynx with the smooth bulge posteriorly, and that's retracted cricopharyngeus. Now, we wouldn't necessarily be glib in all situations and say that's what it is, but that appearance, particularly the one I showed you, is so characteristic, I think you'd be quite comfortable in calling that muscle and not tumor. Okay, pressing on to question 3. A Zinker's diverticulum is midline, traction diverticulum, below the cricopharyngeus, lateral. Formulate your answer, please. Okay. Obviously, from the case I showed you, Zinker's is a midline defect. It carries through Killian's dehiscence. The other point that it is not a traction diverticulum, it's a pulsion diverticulum. I may not have made that clear in our talk, but it's the type of diverticulum that occurs when there's usually increased pressure, often in prominent cricopharyngeus, and that's at least postulated as a reason for a Zinker's diverticulum. Below the cricopharyngeus is not the case. That usually is a diverticulum that tends to be lateral, not midline, and it is a Killian-Jameson diverticulum, which is the guy that's lateral and not Zinker's, which would be selection D, which you didn't choose. Okay? Now to question 3. A type 3 hernia is A, hiatal, B, paraesophageal, C, includes tail of the pancreas, D, hiatal and paraesophageal. Formulate your opinion, please. I'm sure you all chose D. Hiatal hernia is a type 1. Paraesophageal is a type 2. If it includes viscera or mesentery, that's a type 4. So a type 3 is hiatal hernia and paraesophageal hernia. Okay. Moving along. Question number 5. Adaptation can be seen as a feature of celiac disease, choice number 1. Microscopic villus hypertrophy in the ileum, number 2. After small bowel trauma, D, all the above. And formulating your answer, it's obviously all the above. I showed you a case of celiac disease. Here the ileum is trying to take up the slack for what the jejunum can no longer do. And so there is, if you look at the height of the villi in the ileum in a patient with celiac disease, you can see it almost assumes the same anatomy as that in the jejunum previously. As you know, what's occurring at the villus is in the crypt you have the pluripotential cells. And as those migrate toward the top of the villus, you have maturation to whatever cell it evolves into, and then you have apoptosis and sloughing into the bowel lumen. That's a fairly rapid process, so the villus turnover is very rapid as well. That being said, you can have an enormous amount of adaptive change. That, you have to realize that also represents an enormous amount of bowel wall turnover, protein loss, fluid loss, etc. So that goes into the equation of someone who might have, say, a short gut syndrome. Moving on to the next question, thumb printing. Thumb printing is seen. C. difficile colitis, ischemic colitis, patient with pneumatosis in portal venous air, all of the above. And the answer is all of the above. I didn't address this directly, but most of you know that one of the sequelae of having C. difficile infection and or having ischemic insult to the colon is then either positive pressure, introduction of gas into the wall, giving pneumatosis coli, or gas-producing bacteria invading the wall, or necrosis of the wall because of ischemia. When that occurs, then you'll have air which is taken up into the portal venous system, ultimately embolizing back. And obviously also that's a sign of extremis for the patient. Pneumatosis coli, pneumatosis in the bowel in general, is an interesting and complicated topic, perhaps for another day. I'd encourage you to look at that as a separate issue, because about 15% of the time, that's a benign process, and usually idiopathic, though you can postulate some etiologies. It's the 85% of the time when pneumatosis is seen with entities such as C. difficile or with ischemic bowel that serious precautions and intercessions have to be entertained. And now for have I gotten to the last question yet? Oh, I have. Thank you. Okay, here. Please email your questions to us, and we're going to pause for a couple of minutes. Thank you, and stay tuned. Okay. Welcome back. So we have a couple of questions to address. Both of them are interesting. The first one reads as this. With regard to aging patients, what is the incidence of diffuse spasm compared to achalasia? Is this diagnosed as all other causes are ruled out? That's a very good question. One of the things I think you're asking about, and it gets overlapped, and that is patients who have what's been called presbyosophagus, and what really is spasm for one reason or another, or what might overlap into achalasia. Presbyosophagus is disordered esophageal motility seen in older patients. As you know, the normal esophageal motility should consist of primary wave and stripping wave. The primary wave is an inverted V, and as you watch fluoroscopically, you can see that go from the cervical esophagus all the way to the LES. If you follow the top of the V. It should progress proximally to distally uninterrupted. If it dissipates, then we would call that dissipation of the primary wave. And that's an abnormality. Now, what's the problem there? Could it be a muscular problem? Could it be a neural problem? If you look at all comers, far and away, the most common problem in younger patients is going to be reflux with inflammation of the bowel wall. In older patients, disordered motility is very, very common. I think what's different in the appearance of it, though, is that in patients who have spasm, as opposed to sort of the disorganized trajectory of the barium bolus, if you will, down the esophagus, it tend to go to and fro. When you're watching fluoroscopically, spasm looks hard. It looks like the esophagus is really working. And there, in patients who don't have achalasia, the spasm tends to be disorganized. It tends to be up and down. You'll see a to and fro motion of the barium, particularly, as you know, you should be evaluating motility with the patient. Prone RAO, removing gravity from the equation, so not upright, so prone RAO. That said, to and fro motion of the barium column due to spasm, that's pretty typical. That'll go back and forth. In patients who have achalasia, you'll tend to have that fairly organized corkscrew type pattern, particularly as you start getting closer down to the LES. So the long and the short of it is, presbyosophagus is really common, but doesn't have the vigor that you see in patients with spasm. Spasm not due to achalasia tends to be more of a to and fro motion, and the esophagus usually isn't that dilated. And also, as you're watching it real time, the esophagus isn't contracting real hard like you'd expect. Achalaic spasms or vigorous contractions against the closed LES have a fairly characteristic appearance, so hopefully those wouldn't get mixed up. Moving on to the next question. For first-year residents, it's especially useful to understand your method for determining the viscosity of barium. Any tips? Well, fortunately, most of that has been solved before it comes to you, but I'm going to go over some general ideas for where you would use what viscosity and why. If you want to evaluate the morphology of the esophagus, look at swallow, look at the lumen configuration, the same thing pertaining to a distended stomach or small bowel or colon, then thin barium is fine. Leave the colon off for a minute. I'll come back to that and make it a special case. As you thicken the barium, you have greater coating of the mucosa. So wherever you are and however your barium viscosity is graded, The thicker barium is used to evaluate for mucosal abnormalities. So, for instance, just before I came over here, I did a dual contrast upper GI on a patient, and I was concerned because she had a peculiar history of sprue, but also had developed a lymphoma that hadn't been typed yet with dysphagia. I was afraid she had mucosal lesions in her esophagus, so I gave her crystals before doing the exam, insufflated the esophagus, then gave her very viscous barium to coat the esophageal wall to look for ulcerations. I saw none. I also, with crystals in her stomach, the thick barium was now there. I rotated or coated the gastric wall. I didn't see any ulcerations in the gastric wall. I then went to thin barium and looked at the contrast column, motility in the esophagus, and also the filled stomach to see if there were any masses or filling defects, then carried on and looked at the rest of the bowel. I think that's a good rule of thumb. If you stick to that, that should serve you well. And that's all I've got.